Good afternoon, everybody. It's my pleasure to introduce Dr. Sonia Ramamoorthy, Chief of the Division of Colon and Rectal Surgery at UC San Diego Health and Professor of Surgery at UC San Diego. She is a leader in minimally invasive colorectal surgery and research spanning colorectal cancer, inflammatory bowel disease, and physician well-being. Please join me in welcoming Dr. Ramamoorthy.
Thank you, David, and thank you to the entire group for allowing me to speak with you today. I have not been asked to talk on this topic, so it was really actually exciting. And I know you are all the experts, and I'm kind of the visitor here, so I certainly welcome discussion on the topic. So I am going to share my screen here. I'm just going to make sure you can see what I am seeing. Are you able to see this? Okay, great. All right. So I was asked to speak on surgical response to pandemic preparedness and some of the lessons that we learned from COVID-19. And there were so many lessons learned from the pandemic. It's hard to compartmentalize it all into a talk, but I'm going to do my best. I will mostly be speaking from the perspective of what I experienced as a practitioner here at UCSD. And what I also learned on the national front from the American College of Surgeons and my society, the Society of Colorectal Surgeons. So why it matters is surgery really sits at the intersection of um, everything from elective to emergent care. It is resource intense. They say that surgery costs between $50 to $150 per minute in the operating room. When you think about all the costs, all the personnel, and all the resources that are in the operating room. So you can imagine when everything came to a screeching halt, how much was required to think about how we triage services and how do we then resume services. And turning off and on a switch like that is not a simple thing to do. We had to think a lot about our patient vulnerability. Who was at risk if we delayed cases, and how long could we delay things? What was really essential surgery versus elective surgery? And so we'll talk a little bit about that. But we forget sometimes that surgeons also run clinics, and we manage a lot of non-operative cases as well. And part of that process also includes the preoperative evaluation of patients. Are they safe and optimized to go to surgery? So a lot was impacted, as it was for many practitioners during the time of COVID. We go through a process by which we see somebody in clinic. We determine they need surgery. We put them through a preoperative evaluation. Then we put them through an operating room scheduling system, which we have to be sure that we have appropriate staffing and equipment that we need. And then many of those patients require inpatient admission and then post-operative care. So there's an entire sort of process that we have to go through when we're taking somebody through surgery, either a very simple surgery or a very complex surgery. And so we learned a lot through this process of going through the pandemic. So what I hope to share with you is sort of a review of the experience of operational issues that we encountered during COVID and some of the clinical lessons that we learned on surgical services, summarize some of the perioperative risks that we knew at the time and that we've learned subsequently, and how we manage the backlog recovery, which I feel like we're still in recovery mode. Highlighting the pivoting of in-person visits, which surgery can be very hands-on, right? Determining if someone has a hernia there or someone has a hemorrhoid there is typically a physical exam finding. How did we accomplish that with telemedicine, and could we make patients feel taken care of when we could only see them through a teleprompter? And then defining a forward-looking preparedness framework that we've had to lean on for various other issues. Thankfully, not pandemic, but things like strikes, where suddenly there's no staffing, or God forbid in the future there's any kind of situation where the OR or the community is at risk and we have to triage our services like we would during a pandemic. Okay, so the first shock was when all of us found out, oh my gosh, we're having to curtail our operative services, and surgeons were told the OR is going to close, and clinics were closing, and that was a big shock. And part of it also was there was a little bit of a disconnect between what we were hearing from our colleges, the American College of Surgeon, and what was going on, for example, at UCSD. And there was a little bit of uncertainty on both ends. And from what I experienced was our local leadership was saying, okay, we're not sure we need to change our operative services just yet. And this was, I remember very clearly, like on a Thursday where I had called all my staff in and said, okay, we are going to switch to telehealth visits right away. People need to download all the necessary software. You need to have your computers ready. You need to, be able to pivot very quickly, and the staffing that was going to go along with that, and making the phone calls to patients, because it was Thursday and we had a full clinic, full OR schedules that following week. And that was really based on what I was learning on the national front, a little bit of what was going on in other places, but a lot coming from the American College of Surgeons. And yet my local institution hadn't quite come to that conclusion yet about elective cases. And so there was a lot of back and forth in those 48 hours, if you can remember, because we weren't exactly sure what to do, what was going on, what was happening. And so we made those determinations, and by Friday that afternoon, that week, we were told, hey, we're going to have to cancel elective cases, and we're going to have to change our clinics to telehealth only. And thankfully, we had started that process about the 24 hours before. So it was a shock to all of us, but I was really very grateful for how everyone came together. So one of the first problems we encountered was what was elective surgery. And it turned out to be a very imprecise definition under crisis conditions. And we found naturally that a lot of surgeons and doctors were advocating for their patients. So they were saying, oh no, this has to happen, even though it wasn't necessarily what we would consider an urgent or emergent issue and could be put off several months if that was what was necessary. So early pandemic guidance required rapid conversion from normal routine scheduling to an acuity-based prioritization. And it took a lot of level-headed people, both surgeons and non-surgeons, a combination of surgeons in anesthesia, nursing, leaders, to come together and pull together our resources and how we were going to approach this problem. So surgical teams had to balance the patient needs against four simultaneous constraints. One was the availability of PPE in the operating room, inpatient bed capacity with the surge that was coming in, ICU surge demands, and exposure risk to patients and staff. And we were learning this while we were trying to enact many of these policies. So essentially building the plane while we're flying it. What was helpful was the joint statements that came out from the American College of Surgeons and the Anesthesia Society, and eventually AORN, the Nursing Operating Room Nurses Association, were able to join in and help us navigate some of these things. So one of the first things they suggested was a surgical review committee. And again, it's made up of those components of anesthesia, surgery, nursing, leaders, to help determine what was essential surgery, what was elective surgery. Because again, if you leave it up to doctors, we're all advocating for our patients and we all believe that they needed stuff done. And a lot of patients were calling us all the time saying, I need this done right away. But someone who's having a symptomatic hernia is very different than someone that has a near obstructing colon cancer. So you can see in some cases, it wasn't too hard to figure out who needed to go first, but in other cases, people could be very symptomatic, in a lot of pain from their disease. And those are all things that we had to take into consideration. We learned also during this time about perioperative rest, and we weren't totally aware of it in the moment while we were living it. But as the data started to come out, we certainly started to realize the increased risk of our patients who were testing positive for COVID. And then there was, of course, a difference between those patients that tested positive, they were symptomatic, versus asymptomatic. So what we've learned kind of in retrospect that around, depending on what study you look at, there was somewhere between 20 and 40% 30-day mortality associated with infected surgical patients in an international cohort study for those who tested positive for COVID versus those who did not. So this is outside of your normal operative risk. And if you're testing positive for COVID, you had a higher mortality. Pulmonary complications naturally were higher in those patients who had COVID. And again, there's a big difference between someone, as we've learned later, that might be testing positive that's asymptomatic versus someone who's very symptomatic. And in the beginning, I would say that first couple, 2-3 months of surgery, we were taking patients back to the operating room who were in the ICU and very sick with COVID. And we honestly didn't know what the risks were. We knew we were all at risk in the operating room, but we didn't know what else to do because in some cases, patients were at risk of dying if we didn't do an emergent operation. Outside of this, we've learned a little bit about bleeding risk, higher fibrolytic activity that increases potentially the risk of clots and then the counter risk of bleeding as a result. There are a lot of meds and things that we give patients postoperatively, typically to treat in a patient to enhance their recovery that wasn't necessarily appropriate in someone that had COVID symptoms. So a lot of things that we had to learn and relearn during the pandemic. This is a study that came out of JAMA, and it was based on Vizient data and looking at typically urgent and elective cases from all different specialties. And you can see here that COVID itself, now this is kind of retrospectively looking at it, which is really nice for us to better understand these things. And the paper is interesting because it does break it out by community hospital, nonprofit hospital, and private hospital. And there were some differences, but the overarching finding was that there is an increased risk of mortality for those patients who are testing positive for COVID versus those who are not. Complications, however, weren't too different between the two groups. So maybe that reflects a little bit of eliminating a very, very high risk group of patients that were just totally unsafe to go to the operating room. But if you were safe enough to get to the operating room, we could get you through the operation with surgical complications remaining about the same between the two. Hospital-acquired conditions were increased in the patients with COVID. Patient safety indicators were also slightly higher in the patients who had tested positive for COVID, but interesting length of stay between the two wasn't any different. Well, what were some of the operational vulnerabilities that were exposed during this time? The OR was not living in an independent situation, but OR access and inpatient bed access are inseparable. We run into this all the time with surges that we get from the ER, and then we can't do elective operations because there's no ICU beds. And many of the patients we take to the operating room, either because of their inherent comorbidities or because of the operation we're doing, require ICU beds or monitored beds. And of course, that became very challenging during COVID. So not only did we need to operate on the sickest people that needed operations, we also needed a place to put them after. And so we had to really work very closely with our hospital leadership, our hospitalists, our intensivists, our nurses, to figure out how we were going to safely take care of these patients. That meant getting and finding ventilators, using more positive pressure ventilation, some of our CPAP machines and people that we normally might keep intubated. It required staffing, a lot of pressure on our respiratory therapists. It put a lot of pressure on our blood supply. And again, you can't do cardiac surgery or transplant surgery in patients unless you have an adequate blood supply. So it really put the entire system under pressure. And God forbid you were just a regular patient that might have bleeding and need a transfusion. These were all things that this review committee were having to deal with. And it really forced all of our teams to work so closely together and be in touch with each other almost, on a minute-to-minute basis. Surgical preparedness really required real-time situational awareness. And I want to shout out to our perioperative group, Dr. McHale, Dr. Waterman at UCSD, because they were really hands-on during this time in the hospital every day, or always available by phone. A lot of surgeons were critically dealing with critically sick patients and needed questions answered on the fly. And they were always picking up and always responsive to us. We did find that there were a lot of challenges with supply chain. So the N95s were coveted and you only got one if you really needed one. And in the operating room, we needed to have that PPE, the donning and doffing of all of our outfits, and what the current recommendations were changing by the week. And so learning all of that, teaching all of that, and making the supplies available so people feel protected while operating on this vulnerable patient population was really important, and maintaining team morale. And part of that was just feeling like your health system had your back when it came to your own safety while you were taking care of very sick patients. Preparedness has to include inventory visibility, and we did not really have to deal with that in the past. We always had an abundance, especially in this country and at this institution, of things that we needed. And we didn't know what it felt like to not have enough of something. And that's perhaps how you feel in many underprivileged parts of the world and even parts of our country. And so it really increased our visibility, our thought process about how do we utilize and ration some of our resources very carefully. And so this has led to more conservation protocols, contingency sourcing, and not solely relying on just-in-time supply chains. So we knew that for some of our most intricate operations, that we not only had to have the frontline workers available, we knew we had the patients there and the supplies immediately available to us, but we needed to have potentially backup supplies available and rely very heavily on our supply chain. And thankfully, it was really great to be part of the UC system that often shared a lot of resorts. I know Dr. Byington's on the call here, but she was very critically important to the CEOs working together to share resources when necessary. And so it felt really good to be part of a big system during that time. The surgical workforce, where this was a tough one because we were telling people not to come in the hospital, right? So we would only deploy our residents and trainees where they needed to be. Medical students were often told to not come in unless, it was necessary. And even having partners around. So one of the benefits we have as surgeons is we have other surgeons around. And if there's an issue in the middle of an operation where you might need help, and that happens not so infrequently, you want to call someone and, hey, can you take a look at this? I'm a colorectal surgeon, but I might need the urologist here on the fly because we didn't realize this thing is involving the bladder or some other tissue. None of that was going to happen during COVID. So we often found ourselves having to deal with issues, FaceTime people, talk to them on the phone. And thankfully, again, the collegiality was unbelievable and off the charts during this time. And we were able to work our way through it, but we came to learn these lessons. And I will give you a personal example. I was scrubbing into a case. There was nobody else in the hospital, none of my partners. And my resident was there, and they had just come in that day to do that case, right? We're in COVID times. There's not that many people in the hospital unless you need to be. And right as I was scrubbing, I got this very funny page. And so I actually stopped scrubbing and I answered the phone, and my husband, who's okay now, but had been in a really bad bike accident. And normally what I would have done is called my partner to come in and take over for me so I could go take care of my family member. But there was nobody in the hospital. And so I actually had to call my friend to go get my husband. He was in an ambulance. He was going to a hospital, and to be there with him because my patient was intubated on the table, and there was no way I could leave that case in that moment. So some of the luxuries that we have during non-pandemic times really changed how we function during the time of the pandemic. And for the most part, we weren't running an elective schedule. So a lot of surgeons and anesthesiologists were not, if they weren't doing telehealth visits and then they weren't operating or not on call, what were they doing? Well, we were redeployed to many other places, ICUs, the wards. We consolidated services. So as a colorectal surgeon, normally I'd only round on the colorectal service, but we deployed ourselves to round on our colleagues, Surg-Onc, MIS, urology. We would all group round so that it required fewer and fewer people to be in the hospital, fewer people to be exposed. The highly trained scrub nurses that you have, that team in the operating room who knows exactly what instruments to get you and all that stuff, that was all gone by the wayside. And we had to become much more patient with each other. But operations did take longer because you did not have that technical team and that technical support that you always had. You also had people calling out at the 11th hour, which I'm sure this group is used to, right? So you knew to expect that. We didn't know what that feels like, but now we do, which is you thought you had help. You thought you had your resident coming in, but it turns out your whole resident team now is tested positive. So we had to learn to sort of figure out how we were going to work around some of those challenges. Um, and of course, protecting the trainees. I think on top of taking care of patients, you wanted to take care of your people, the young people, make sure that they were not going to be exposed unnecessarily. Happily, I think one of the things that happened is, most of us surgeons have ADD, and we like to use our time. We didn't want to sit at home on our hands, and so this is the COVID vaccine. That large clinic or outposting that we had at the stadium out there that UCSD ran, and we were out there at Petco Park vaccinating people because that's what we wanted to do. And the funny thing about it was most of us surgeons are used to, you know, making incisions in people and doing intricate operations, dealing with bleeding and organs and trauma and whatever you do, resections. But when it came to giving someone a vaccine, we were totally nervous. Like we had never given anybody a shot for anything before. So I was absolutely terrified that I was going to hurt somebody in their arm by sticking a little 25 gauge or 22 gauge into their muscle in their arm and their deltoid. But, I have no problem cutting somebody open. So it was kind of one of the funny things. Okay, PPE, aerosols, OR safety. So COVID-19 necessitated a radical overhaul in infection control protocols, especially concerning aerosol-generated procedures. We didn't know. We're boving people all the time in the operating room, and so that creates a lot of smoke. And even though we're wearing masks, we didn't know if we were aerosolizing COVID-19, and we were worried about that. So we stopped using typical bovies, and we started using bipolars that doesn't necessarily generate smoke. We also, of course, had the N95 masks available to us. We were wearing significant eye protection and fluid-resistant gowns and gloves. So there's a variety of different types of gowns and gloves that you can wear in the operating room. If you're someone who does robotic surgery where you're not, the incisions are very small and you're not going to be encountering that much blood, you tend to wear lighter gowns. But if you're someone who does more open surgery where there could be a lot of blood, like a liver transplant, you're going to be wearing much higher grade gowns. But for the purposes of the pandemic, we definitely were using the heavier grade gowns, but those were not available in abundance. So we had to be thinking about those cases where we really needed to use these gowns and be very protected. I remember some of the surgeons double gowning just because they thought that would be that much more protection. Just gives you an example of what we know and what we didn't know, even though we were dying of heat. They were strict, the donning and doffing of the procedures that we had to get accustomed to. In the very beginning, like the very first cases we were doing on COVID patients, they were having us go into an ante room and with all the negative pressure, and we were changing there and going in and operating and then changing out and coming out through that ante room as well. So there was just a lot of fear in the beginning that thankfully our ID folks helped us understand more about what we could do, what was safe to do, and what was appropriate PPE in the operating room. We certainly evolved our techniques for reducing aerosolization, like I said, using bipolar instruments instead of monopolar, using smoke evacuators, which we typically don't use for every single case, but we were using it during COVID, and we just needed to make sure we had an adequate supply of smoke evacuators in the room. And again, learning about the different type of PPE that we could use and in what cases. One of the unfortunate side effects of the pandemic was deferring surgery and people deferring care. And more true, again, in underserved areas than in our own area. But even in our own area, people were scared of COVID and wouldn't come in with serious symptoms, or people who were in the midst of a diagnosis of cancer, not getting adequate treatment during that time. So what ended up coming into our emergency room were people with emergent cases, perforated cancers, cancers that had spread all over the place. And we continued to see that in the years following COVID because of the deferred care during this time. And this is just some data looking at that, a 15% increase in upstaging. I think it's much higher than that for the people who deferred care. You would have an early stage cancer progress to a late stage cancer. 34,000 deferred surgeries. I think, again, it's much higher than that for people who would undergo non-operative management of their cancer when what they really need was operative management. And 2 times the mortality risk. Again, I would argue, just based on what I saw in my own practice, treating colorectal cancer and working in the cancer center, that all these numbers could be amplified because that is what we experienced in the years following COVID. So a lot of delayed care, particularly hitting the cancer population very hard. I think one of the things that we learned as a wellness director was we were suffering right along with our patients as a healthcare workforce, watching our patients suffer, watching our patients die, taking care of people and burning out and not being able to take care of our families. There was a lot of mortal injury and burnout during this time. And I do think while burnout and wellness for our healthcare workers was an issue before the pandemic definitely brought it to the surface. And so you see many hospitals, including our own UCs, building out these wellness offices as a result, because there was a tremendous amount of grief and burnout and moral injury amongst our healthcare providers and surgeons and anesthesiologists. The nurses, the OR staff weren't any different. One is the ethical conflict of having to choose who you're going to operate on and who you're not going to operate on, who you're going to make wait, and just watching patients suffer and having patients be very angry with you too for canceling their case or moving their case along. Burnout, because if you're someone who's a frontline worker, whether you're in the ER or in the ICU or doing emergency general surgery or emergency surgery of any kind, when your colleagues were out, you were working longer hours and you were seeing worse outcomes. And it was a very emotionally exhausting time, I think, to be a healthcare worker. And then dealing with a lot of grief and loss. I think one thing that's lost in all of this, but I saw it as a healthcare worker, is many of my colleagues lost family members during this time, but didn't have time to grieve, right? They had to show up to work. They had to take care of humanity. And it took a toll on them for sure. So, what good came out of this? We built out a lot of wellness programs throughout our healthcare systems. We started to recognize the importance of peer support, and we started creating more mental health outreach for people because so much came out of this pandemic that was very challenging and adverse for our healthcare workers. I know there's a lot of people here who do a lot of global health, but nothing like the pandemic to really bring out the inequities. And healthcare and surgery was no different. Those high income countries, they were overwhelmed, but generally resilient systems were able to establish infrastructure quickly, rebuild a supply chain, deploy their workforce. And while there were temporary delays, there was a mechanism by which patients could get care. But in those low and middle income countries that were already dealing with chronic shortages and workforce and surgical access, it just became 100 times worse. And so we lost a lot of people during that time. And it became very acutely clear that those problems were magnified 1,000-fold during times of pandemics. I saw a lot of my colleagues as we were coming out of the pandemic, traveling to foreign countries to try to help support the catch up for the surgeries that needed to be done in areas of Africa and Asia that were so severely impacted. But whatever was felt in this country was felt a million times over in many underserved places. Communication as a clinical intervention, this was really important on so many levels, right? So operational transparency builds trust, and I think it was really important that we made the process for how we were deciding on what is essential surgery and what is elective surgery clear to our surgeons, so that they had the appropriate talking points to talk to patients. They were definitely on the front line, our doctors and nurses, and they were taking a lot of heat from patients. Naturally, everybody wants care. They believe their care is important. And we had to give them the rationale for getting tested. When do they need to get tested? Visitor restrictions, individual risk, the delay in care, and just still maintain that trust between the healthcare system and our constituency. We also had to do more on informed consent because we didn't know what exposures might be exacerbated by the pandemic. Team communication was really huge. I spent a lot of time talking to my team during COVID, more so than normal times, because there was such a need for communication, and because communication was the only way in which we could address some of our patient care issues. And so having our leadership tell us what was going on so that we could pass that and trickle down that information to our staff and to our faculty and to our patients was really important. So frequent communication was really important, and then being transparent about what you didn't know was also really important, and sharing information that you had. I remember we were doing some of the first operations for colorectal surgery. And then we had a town hall nationally with our colorectal society to talk about how we were managing it and to hear about how our colleagues in New York were managing it. It was really important for the rest of the country to hear. It was not meant to be like, this is the best way to do it. It's just like, here is what we are doing in our hospital. And people were sharing different stories. That was really important. And then situational dashboards, real-time operational visibility, bed capacity, OR availability, which has carried on into post-pandemic. So people liked getting that information, and we knew that was true. And so being able to sort of continue that in the post-pandemic has been really helpful, because we saw all the surges that happened after the pandemic, and it hasn't let up. We've also had other crisis situations, like when people go on strike, right? And our staffing levels are low. And when we have to make some of these important decisions, we have a history with our leadership. We have a pathway for which to do that, because we've been in this circumstance before. Telemedicine. So that became an infrastructure, a really interesting thing for surgery, because we always see patients in person. And we hadn't really engaged in telemedicine. It was kind of this thing that was out there in left field that some people were doing. And we never thought that was going to be part of our practice. But very quickly, we had to move to telemedicine visits. So how are we going to do that? It was amazing to me how quickly our EHR system pivoted towards telehealth, how much our IT group and our information group helped us to learn how to do telemedicine very quickly, made it very user-friendly, and how willing everybody was to learn, because they realized that patient needed care. And patients pivoted very quickly. And thank God we all had smartphones, so we could all make this happen. And it was a little bit of a learning tree, but we got through it. And how did we manage taking care of surgical patients? Well, so post-op patients were relatively easy. We just had to ask them how they were doing, what was going on. Can you show me your incisions? For the most part, I would say post-op care was pretty good. Pre-op care was the challenge, right? So someone has a hemorrhoid, I don't know, we're exactly going to be able to see that on telemedicine. So we spent a lot more time talking to patients. Tell me about your symptoms. Tell me about what's going on. We really had to be very acute diagnosticians with a history and no physical to be able to figure out what was going on with them. And for people you weren't entirely sure, like, do you have a rectal cancer or are you just having constipation? Sort of continuing to check on them, trying different things and checking on them, and then figuring out when you really needed to bring someone into clinic. So we didn't completely cut off clinic and surgery, but we definitely had to triage patients via telemedicine as to who we needed to bring in to do a visit. And it meant spending a lot more time talking to people to figure out what the problem was, in as much as it was possible for them to show us the problem, take pictures, send us what those things are in my chart. That is how we honestly managed during that time during COVID. It doesn't replace surgical clinic, but we knew how to do it, and we knew how to make it work when it was necessary. We did a paper on patient experience with telemedicine. It was a paper between colorectal and otolaryngology. And we didn't know how our patients were receiving the telemedicine option during the pandemic. I think most of them would have preferred to come in, but we were trying to do our best, and we were trying to gauge their satisfaction with the visit. And to our surprise, patients were overall satisfied with this option, naturally concerned about coming into a clinic setting during a pandemic as well. So you can see here the mean satisfaction was pretty good for patients with telemedicine encounters. And colorectal and otolaryngology are two specialties where you actually put a scope in and take a look to see what the physical exam finding might be. So it's amazing that patients felt okay about it, and that the practitioners felt pretty good about it too, that we didn't miss too much during that time. And brought in anybody that we had a concern about. 96% said they would use it again. So patients reported a willingness to use telemedicine again. I'm not sure we would have made this transition into telehealth and video visits had it not been for the pandemic. But here we are, and it's a great modality for us to deal with patients, especially some homebound patients where it's very difficult to come in. And in terms of cost savings, it was $108 we found in saving per visit for patients not having to come in, not have to transport, and not put anybody at risk. So overall, we felt it was okay. There was 61% of patients who still preferred an in-person visit. Naturally, they have a surgical problem. I would say that number is probably lower today as people get more comfortable with what telemedicine has to offer, as well as the option to come in if they want. I think it's just feeling that option that you can see your doctor in person if you need, that probably alleviates a lot of the concerns that patients have. 36% felt that the quality of care was hindered, at least somewhat, by the absence of a physical exam. There is no question about that. It would have been much better to be able to examine patients in person, but knowing that we had no other option in some cases, to know that around 2/3 of our patients were still pretty satisfied with the absence of a physical exam and a telehealth visit was still reassuring. All right, just finishing up here, the hidden epidemic, the backlog and deferred harm. Recovery was not so simple for us. All of a sudden, there was this backlog, a year's worth of hip replacements that needed to be done, a year's worth of hernias that needed to be done. So how do you redeploy and get everything back on track? The modeling estimated that 28.4 million elective operations were postponed during the pandemic, during the peak period of the pandemic, which is a significant number. So, we were having to add some Saturday times to the operating room schedule. We moved a lot to the outpatient surgery center. So interesting, it was inpatient surgery that was challenging because the hospitals were full, but we could still perform outpatient surgery. And then it was just a question of the resources and the safety of it. But if the patient was testing before surgery, COVID negative, and you still felt the surgery needed to happen, it was possible for us to still do outpatient surgeries, and we were still doing those. And I think that really still helped our financial bottom line for the hospital to keep things going. So, but when it came time to open up the floodgates, recovery was not so simple. Even with a 20% increase in surgical volume, the median backlog was estimated around 45 weeks. I would say in my practice, the backlog was about 6 months. Recovery required redesign, not just harder work, because you couldn't make people work 24/7. That wasn't the goal, but we still had a lot of cases that we had to do. Pushing some things into the outpatient, again, still doing triage in this time period as to who needed to go, and our OR staff making available more evenings and weekends did allow for us to help work through some of that backlog. Strategies for that included prioritization of the framework, ambulatory migration. So this is where, in my field, the same-day colectomy was born. We used to operate and take out patients' colons, a section of it called a hemicolectomy, and then they'd be in the hospital for 5 days. With enhanced recovery, we dropped that number down to 3 days. And then during the pandemic, a national effort was developed towards same-day colectomy. So we would do the colon resection in the morning, keep them in the recovery room during the day, and they would go home that night. And so there are some very healthy patients that need resection that are good candidates for this. And that momentum has continued post-pandemic, where we can do same-day colectomies in patients. Doing some digital pre-op and post-op workflow redesign was really, again, born out of COVID, which was a good thing that came out of it. We're getting patients home. We found that it's safe to get them home, a select group of patients. We found that we could use wearables to monitor them. We could do telehealth visits to see them post-op day one and make sure they were doing okay. And as long as we were good about our selection capabilities, most patients did just great. We actually didn't have any complications in that regard. Historical precedents, pandemics, surgery before COVID. We had never faced anything like this before, right? We've read about it. We'd had small outbreaks, SARS, H1N1, Ebola, but these were all things that seemed remote from us and not something that was immediately affecting us in our practice at UCSD. But COVID-19 taught us a lot, and it's taught a generation of physicians and trainees about how to deal with these crisis situations. God forbid we have to deal with it again. But we have these minor issues that come up from time to time, like I described, either strikes or, there could be natural catastrophes that lead us to have to, again, go into a little bit of a crisis mode with how we manage the operating room and how we manage the hospital. And thankfully, we have some experience with that now. Surge capacity, scaling surgery in a crisis. We learned about rapid conversion and expansion, how to repurpose our ORs if we needed to, how to repurpose staff if we need to, implementing crisis standards, figuring out appropriate resource allocation, patient triage, and the communications that need to happen around that. Switching our protocols from our regular standard operating procedure to one of a crisis mode, where we can quickly know what to do and how to do it, and who will take the lead at that time. And this just helps build future resilience. There's a good feeling about knowing that you're prepared to face any challenge in the future, especially when you're a frontline worker. We super grateful for all our infectious disease colleagues that helped protect us during this time. I would say my experience was surgeons, for the most part, were very well protected. We were worried about it in the moment, but we were well protected during the moment. We received a lot of good advice. We didn't expect it to be perfect, but there was great communication from our infectious disease colleagues. And I think it brought all of our faculty closer together, all of our healthcare workers closer together, and this was an important outcome out of COVID. We learned a little bit about the different masks, which ones we use. We learned a lot about aerosolized protocols in the operating room. We learned a lot about how to appropriately triage ventilation and air exchange for our very sick patients and in the operating room. We've learned about universal masking. When the flu season is high, you don't get pushback from anybody anymore. Everybody's willing to put on their mask when they're supposed to. We also have much more, I would say, sensitivity and thoughtfulness around intubation and extubation, right? We take those times very seriously. When we see a patient that we know may have an infectious disease, we're very protective of our staff and our faculty and our trainees around the room when we're intubating and extubating those patients. We rely heavily on anesthesia and our CRNAs for the management of the airway during this time. And we have a lot of protocols now in place when we are in a crisis situation. We know more about OR biosafety. what does it mean when you test positive? What does it mean when you test positive and you're symptomatic versus not symptomatic? And we understand, um, what that risk might present to the system, and to the groups that are working around these patients, and what is the risk to the patient itself. And then, of course, finally, supply chain was a big issue, across the hospital, particularly in the operating room, as people get nervous very quickly and buy up a lot of the supplies of everything and can leave us without the necessary stuff that we need. So I have to say, people learning a little bit more about that and being more judicious and the equipment and the resources they use was a good outcome from this. Framework for next time: ethical triage. We know how to prioritize patients. We know how to prioritize the process for prioritization, and we know how to communicate well across the system. The digital infrastructure certainly helps. Patients and healthcare workers are now very well versed in the digital infrastructure. And so if we ever had to pivot again, I think it will be less of a burden on the system than it has been in the past. We'll know exactly those patients we actually need to see in clinic versus those that we can continue to monitor in a video-based and digital-based environment. Workforce protection. Again, we're all much more educated about it. We don't need to go and hoarding all the N95s. We know when we need to use it, and we eliminate chaos and lack of education that leads people to feel like they're not being taken care of and that the system doesn't care about them. We are more respectful of supply chain. Boy, did we learn a lot about supply chain, and we've learned to use our resources more carefully. And we've also learned a lot about planned recovery. So if we're going to put the brakes on something, we plan to upload, for example, more recently, the strikes that put the OR on hold, we've learned to build in some extra capacity before the strike and after the strike that allows us to avoid having a huge backlog. All right, that's all I have. I'm happy to answer any questions. I do appreciate your time and really all that you do to help support what we do.
Sonia, it's Carrie.
Carrie?
Thank you so much for that great overview. And I'm wondering if you have published your framework, because I think it is so valuable for others to see the lessons that you've taken and what has continued forward, and how we can be better prepared for next time.
Oh my gosh, I haven't thought about that except for when I was putting together this talk. And if anybody wants to publish with me, I would be super grateful because I want to put it, I would love to. Because when I was doing the lit search for all of this stuff, a lot of the data is coming out of the moment of COVID and then a year or two after, but not this kind of reflection after the fact and
It's
how it impacts what we do today.
it's really important. And I wrote the after action report for the UC system. But it doesn't include a specific section on surgical uh, needs, which were very different and also very important for the financial health of the hospital. So if I can help you, please let me know. I think it should be out there.
Let's do it.
Great.
Awesome. Thank you.
Hi, Sonia. This is Jennifer Yor. I'm with the SD-CFAR, the Center for AIDS Research. First of all, I wanted to say that I loved your slide on communication as a clinical intervention. I thought that was super fascinating. And I also wondered if there's been a noticeable difference from that implementation point to now, and in terms of how much that has been sustained. Both internally with your teams, but also with your patients and your office staff.
It did. It got us in the habit of talking to each other more and wanting to see more data. And so while we didn't go back to the levels of communication that we had during the pandemic, it is up from where it was pre-pandemic, if that makes any sense.
Yeah.
People really wanted to see what OR capacity was. People really wanted to see what ICU capacity was, because what we found is when you communicated that to the clinicians, they will go and try to create, they'll discharge their patients. They'll figure out, how to create more capacity. They'll work in conjunction with one another to get us to where we need to be. But people just need the why, right? And
Right.
and to help be a part of the solution.
Yeah, I think that's fascinating. I think that's really also really important information to get out there.
Great point. Well, thank you, everybody, for your attention. I really appreciate it. If you have any other ideas, please let me know. I'll follow up with Dr. Byington, Dr. Yor, if you want to work on talking about communication. I'd love to talk about that too, because I think that was a big takeaway out of at least the surgical experience.
All right. Thank you, everybody, for coming. If you have any feedback, I've placed the link in chat for the Qualtrics survey. Please feel free to contact the Prepare Center if either you want to do a presentation, you have an idea for a presentation, or if you know somebody who might be interested in doing one as well. Thank you very much, Dr. Ramamoorthy. It was fantastic.
Thank you for having me.
Mhm.
Have a great day, everybody.
Yes.